and good evening. It's a pleasure to be here. As soon as there. So, okay. Very simply, let me get to the next slide. What we're about is cost management. And me, my partners, one of my partners is here today. We've been at this, looking at this problem for probably better part of a quarter century. So it's no news to anyone to know that we're overspending on healthcare, and to the point we are spending, actually last data is 3 trillion in 2016, 2015 that we have spent. Hospital care, it's a big chunk of that cost. And not only that, consumers, it's beginning to eat up some of the consumers' income growth. And so therefore, in a way, it affects all of us, whether we go to the hospital or the doctor or not, because some of your disposable income is taken away by the overall healthcare system cost and to support it. So how did the government and private insurance respond to this particular problem? Well, one of the things is they have come up with different methods, and they all boil down to shifting the risk away from the payers into on the provider side. Now, suddenly with all this risk to manage patients at a lower cost and a higher quality, basically the healthcare system is struggling because they're really not equipped to handle all that demand. Plus, they still have to treat patients. So one of the things that we are bringing to the equation is restate the obvious. If you can treat patients at an early stage, then there is an opportunity for us to bend the healthcare of the patients at that stage. So the, to your right, I guess, the blue zone is when patients are healthy, and all of us have been or are healthy normally. We don't consume any extra dollars, but since we're not immortals, we'll eventually be afflicted with some disease which will continue to fester, and if no intervention is provided, we will eventually go into expensive treatments and into an acute stage. Now, why do the healthcare system does not treat patients at the earliest stage? I think one of the practical reasons is that there is no reliable tool to identify patients who are in that stage of their disease progression. And that's where we come in. I mean, most, and later on I'll show you a slide, there are, of course, a lot of people in the data analytic space who claim that they are finding you patients in the pre-acute so that you can do pre-acute management, except if you look at what they're doing, they're using 80s technology of risk assessments or simply looking at data, plotting it, and doing a data trend analysis to identify patients that should need greater attention. Our approach is more clinical and analytical, and we have a predictive model that we have developed that can accurately find you patients in that stage, and the rest follows. If you can treat at an early stage, then eventually, statistically, the cost will go down. So this is basically summarizing what I just said. One example of how early treatment can save a lot of treatment dollars is back pain. And of course, we just heard from Dr. Yuli about the opioid abuse, and a lot of it comes from back pain, by the way. So I'll address that in just a little bit in terms of our product description. So first about the tool, we have been involved in developing these types of tools for at least 10 to 12 years. The original module that we developed is being used in a different context in healthcare in identify patients predictively, and we intervene the patients. This was one of the other companies we started, me and my partner and a few other people, to be able to intervene at that point and take them into like a private network of providers. Application here is different, so we have designed the model to come in the middle of the pre-acute zone. We have developed the orthopedic, back pain, cardiac modules, and we've been talking to our potential customers as to what would be of interest to them. Some of those are of interest, but they also want ESRD, kidney disease, COPD. So we have started to develop some of those projects. This is what I was going to describe. This is our, we looked at actually instead of the company that Dr. Yuli used, I used Bessemer Ventures analysis of competitors. And they have listed the top 40 to 50 companies that are active in this data analytic field. And we looked at the whole space of finding patients and preparing them for earlier intervention. And you notice after all of these, and I tried to name some of the major players in each area of that space, but there is not one, including the ones that Bessemer Venture thinks are the leading 40 or 50 players in the data analytics field. None of them are using any predictive model. We are partnered with HealthWise. In fact, we just came back this week, completing the agreement with them. We would be using them for both their educational library that everyone uses, but also in terms of care management, they have lots of tools that they have developed recently that would be useful for us in helping our clients deliver the appropriate care to their patients. Since we are working on COPD and ESRD, we are working with National Jewish. The discussions are in process. We haven't completed any agreement yet, but it's progressing. And ESRD, we are planning to develop in cooperation with the University of Colorado. Our team, Dr. Yuli already introduced me. Terry White has been a hospital CEO, a hospital turnaround expert for more than quarter century. Terry is here today. Dr. Domro, if I was going to come back next week, Dr. Domro was going to make the presentation. But anyway, so at your request, we changed the date. So Dr. Domro is actually a hospitalist. And so he and I actually built the clinical part of the predictive model. And Arman is a software engineer, and he's actually an Oracle expert. He's our product architecture CIO type. And Dr. Myers, not to leave him behind, he happens to be the founder of the SOAP organization, and he's the one who introduced me to Dr. Yuli. And so he's an advisor, has been advising us for quite a few years now. That's it. That's what I wanted to say. Questions? Yes, ma'am.
Yeah, so one of the issues with healthcare is limited access. So if you're picking up all these pre-acute people, do you think mid-levels are going to manage them? Like, how are you making it
Well,
critical?
we are not working in isolation, and we don't want to be a care provider ourselves. We're, let's say, I don't know what the word would be, but a care helper, okay?
Could you repeat the question?
Sorry. The question was that with all these new people being identified at the pre-acute stage, who's going to take care of them? And the answer to that, Dr. Judy, is our whole approach was for reduction of cost and healthcare population management. That's the type of application we envision, although nobody knows what population health management is, but the whole idea is to manage patients early so that they don't become acute and cost a lot of money. So it will be in the interest of the ACOs or any other organization that is working at risk, including regular hospitals. If you're working at risk, our tools should be useful because you'll be incentivized to manage those patients, and it's them that will have to provide the extra capacity that will be needed to manage them. Yes, ma'am. Yes, sir.
What types of structured information does your predictive model depend on?
We have a multi-layered model. Oh, sorry. What are the types of information that our model needs to predict? And it's a multi-layered model. At the very base, we need claims data, and then EHR, EMR data, and then we can even go next level, and you can go up infinitely. But we're considering only 3 levels. So the third level would be self-reported data, like if they have done a genetic test, and if we can get access to the data, that may help us improve. But the decision is made by the claims data and the EHR data, and the third level or future 4th, 5th levels would be modulating that prediction.
What are you looking specifically at in EHR data, diagnoses,
A number of things, including, like you said, what was the diagnosis, what was the results of the lab test that was being ordered, because claims data does not provide that information. And also billing data. Claims data is a little bit lagging, as you know. So EHR data would have the most current billing data available. So and that will have a lot of information about diagnosis and other things. This lady, yes, please.
I'm Margaret Nicholson. I'm sorry I missed the beginning of your presentation, so if you've already answered this, please find out from someone else. However, who is the actual user of your program? Is it the hospitalist? Is it an administrator? Who is assessing all the data and then telling the doctors, hey, this is a patient you need to look out for?
Basically, the question is, who are the users? Well, this is an enterprise level product. So the users are any organization like ACO, a hospital, or a Medicare Advantage plan, whoever is operating under capitation or fixed cost would be the one that would be using it. In terms of who actually executes the treatments and management, that would probably be a care management team of the client. If they don't have the care management team, we would be willing to step up, and that's where our partnership with HealthWise will come into play, because HealthWise will enable, if let's say we have to hire clinical counselors for some type of management, then we can use HealthWise's platform to create the training and the process to do this. But we are really not planning to be very involved in patient management ourselves. It's better left to the physicians and the care managers. Yes.
Interesting question. ACA now in its 4th year, has its faults. We're going to obviously have it longer. It's going to keep going. And of course, from cost cutting, at least it's stopped the so-called emergency room syndrome, which is the biggest cost of all healthcare. Is there anything the ACA and maybe your relationship with HealthWise that you can take forward too, is administratively that would be part of your model? I'm just curious about that.
The question is there anything in the Affordable Care Act which prevails today that would sort of work well in partnership with our program? The answer is probably yes, not as formal as you mean, but one of the hallmark of Affordable Care Act, ACA, is, as you know, the triple aim, cheaper treatment, I shouldn't say cheaper, but reduce cost, improve quality, and I forget what the third one is. But so I already addressed the cost side. But let's say that we are able to avoid some surgeries, which we can, for example. There's so many patients die at the surgery table, and the pain and suffering from recovery. If that can be avoided, that's improved quality of care for the patient. So yes, I think we do support, and the design of the Affordable Care Act really helps. Even if parts of ACA is removed, we wouldn't be affected per se, because savings is the overall goal. And there was, Praveen, you had a question?
I mean, the rationale is fine. I think we don't have to debate that, right? But what's the evidence that you have that your product works and delivers results?
Well, that's a good question. We, as I mentioned, the model was finished in 2012, the basic model, and it has been in use in our previous company, which is, by the way, called Bridge Health Medical. And we have called literally hundreds of patients by now from our model, and we haven't had a single person to come to say that, oh, what the heck are you talking about? You know, I don't have a knee pain or a hip pain. The worst we have heard is that, oh, I just had surgery last week. But that model was tuned to be right at the doorstep of the acute stage. This is pre-acute stage, so it's farther back, and we are actually looking for clinical partners to do a trial and validate the efficacy of that earlier. We've done like alpha trials using just physicians, blind tests, and there's very good correlation with physicians' opinion of versus our model's prediction, but we need to put it into actual trial with a clinical partner. Yes, sir.
What does your business model look like?
Okay, question is what is our business model? In the area where we work, the standard used to be PMPM, but it's now more like PMPY. So we are willing to start at the floor at $1 PMPY per product. So effectively, that's what it is. And it is possible that in the future we could look into savings share, but I've been around in the 90s. I saw many companies lose their shirt doing that because it's very difficult to establish what savings was caused by your product. And therefore, it's a dangerous thing to get into. So we would probably stick for a long time with PMPY model on the population, not just the patient who use it.